안녕하세요. 홍 선생님도 들어오셨나요? 선생님, 안녕하세요.
안녕하십니까.
예, 오늘 8월 17일 토요일 EKG 컨퍼런스 시작하겠습니다. 황채연 선생님이
예,
발표해 주십시오.
네, 안녕하십니까. 저는 강사 2년차 황태현입니다. 오늘 EKG 컨퍼런스 시작하도록 하겠습니다. 제가 준비한 EKG는 다음 EKG입니다. 환자는 트레드밀 테스트를 하던 중에 다음과 같은 심전도를 보여서 트레드밀 테스트를 중단했었습니다.
누가 먼저 시작하실까요? 그럼 윤준철 선생님 먼저 시작할까요? 예. 크게 얘기해야 되게 소리가 들립니다. 마이크 감도를 좀 올리시죠.
와일드카드 스타디하고 레귤러 디프는 일레귤러 것으로 생각이 듭니다. 또 피코디알리 있는 포지티브 컨퍼런스들과 레이트가 약 200세 정도 되는 것으로 생각이 듭니다.
조정원 선생님.
네, 일단 엑시스가 리드 1이 네거티브로 네거티브의 AVF를 때 배리어 라이트를 쓰고 있고 피코달리드에서 18% 베이스만 RR 이 일레귤러해 보이고 그리고 뼈에서에 따른 T웨이브가 보이고 있으며 일반적으로 생각하는 와이드 QRS와는 약간 다르게 약간 RP가 비슷하게
어디 알고 있어요?
예, 컴팩트한 타입에서 뛰어나와 있는 QRS 컴팩트 그 뚜껑은 이렇게 모양을 내하고 있어서 SVT 당하지 않나 저를 시작당하지 않나.
지금 중요한 얘기 하시는 것 같은데 뭘 보고서 SVT를 서제스트 하는지를 정확하게 좀 얘기를 해주세요.
일단 뭐 서비스 하는 거는 RRT 일레귤러하고 QRS의 PF가 관찰되고 있는 것.
어디 싶어서 어느 리더를 딱 짚으세요.
네. AVF 리드도 PF가
요거요?
그 아래.
요거?
네.
요거?
네.
요걸 다 P로 본다는 얘기죠?
네. PF가
P가 원톤으로 가는 것 같다.
네.
근데 그럼 QRS 모양이 이렇게 바뀌는 건 어떻게 됩니까?
리드들
아니. ABF에서도 지금 이렇게 달라지잖아요. 그건 어떻게 됩니까? 네, 운동과 중이기 때문에 달리기하는 중이니까 충분히 흔들릴 수 있겠죠. 아까 그러고 프리코디아 콘코런스 얘기를 했는데 한번 맞는지 팩트 체크를 해봅시다. 여기 라인에서 한번 쭉 내려볼까요? 쭉 내려오면 포지티브. 포지티브 맞아요? 아닌 것 같은데? 포지티브 콘코런스는 아닌 것 같아요. 이 위에는 포지티브고 5, 6 네거티브. 자, 그 다음에 상준생. 우리 원래서는 좀 안 보이게 치울 수 없어.
컨트롤 라이트
잘 올렸다.
올려버렸습니다.
나왔어요. 네, 하세요. 그냥 하세요. 싫어도만 안 갈게지. H.
이거는 또 IDP 목표지를 말씀드린 것처럼 그 라인에 따라 보면은 라테랄 그 V5, V6의 네거티브로 모플로지 크라이테리아, QRS의 모플로지 크라이테리아 IDP 모플로지 RS 레이저가 1 기반이니까 위치 비슷한 것들이 운동 중이라서 그런 건지 모르겠지만 알아야 왜 조금씩 있는 것처럼 일레귤라 스페이스를 간결하게 하고 PAV나 이런 될수 없습니다. PAV는 진짜 QRS의 리스펙트인지 그 디소시에이션을 저거 할 만한 그런
Uh, can you guys hear me?
네, 잘 들립니다.
들립니다.
Okay. Look at the lead one, last three bit. Last three bit. What do you say about that? 그 전 bit, 그 전 bit, 그 전 bit. Why the rate is varying so much there? Yet you don't see any other place. So in other words, RR interval is not regular, this patient,
예, 다릅니다. RR이 바뀝니다.
right? So we are dealing here monomorphic VT, or this is a polymorphic VT, or is a pleomorphic VT. What we are dealing here? If you guys discussing this is the VT,
근데 일단
what do you have to say?
VT를 감별 진단하기 전에 이런 와이드 QRS 그림이
Right.
보이는 VT를 물론 가능성은 제일 높지만은 언더라인한
Right.
번들 브랜치 블럭에 HR 스미어가 동반됐거나 또는
Right.
익사이테이션이 있거나 에버런시를 감별할 것 같은데 에버런시나 프리익사이테이션 아닌 것 같고요 모양으로 봐서는.
Well, if you look at the V1 right bundle branch block morphology, they favor for VT, right? Because R prime first is bigger than second R. And also P wave and relation to the QRS complex does not appear to be constant. Slight different time to time. Another obviously possibility we have to think about is somehow this is not an artifact we're dealing during the exercise, especially 12 leads is not very stable EKG wave line, baseline is very wavy, especially particular lib leads. But the reason I'm asking you is that if you look at the last three bit, look at the RR interval. Is that possible QRS complex bit that fast? How fast that is? RR, is less than 200 millisecond interval there. So you're talking about 320 bit per minute there. Last three bit, take a look. Lead one, go back. If you count the RR, the almost recycling variation more than twice to the last bit. See, you count that? So how can be so fast? Is that possible? I'm asking you. Especially that bit you're pointing at next bit. How the human heart can beat that fast?
리드
Especially-
투나랑 맞춰보면은 그렇게 빠르지 않은 것 같은데요.
그리고 이게
Right. So that mean what does that source represent to you? Why the lead one is also changing so much? The rest, do you think is that all different? But other interval clearly vary widely. There's no question about this thing. And then also morphology is not same, keep changing, right? There's no pattern like I can see. Is there a pattern?
그냥
Right.
짝짝이 모양이 바뀌는 것 같지.
Right. It's every 3-4 bit morphology change drastically. Yeah, that guy differ that guy, and that guy differ that guy, and then also that. So what we call this VT, if this is VT, terminology wise.
이 프리코디알로 넘어가기 직전 비트가 약간 내로우해 보이는 것 같은데 특히 이 V3
Right, but that I think, yeah, that is probably recording issue, rather than true QRS complex. Okay, but if you look at the last 3 bit of all leads, they change it drastically, rate wise, also morphology wise. Look at the lead 1, 2, 3, AVR, AVL, IVF, they all change simultaneously. So this is probably not an artifact real.
근데 모노모픽 BT라고 하기에는 너무 모양이 베리어블하고요.
No, it's not a monomorphic. That's what I'm asking. Is we call this is a polymorphic VT or polymorphic VT if this is a VT?
폴리모픽 BT라고 하기엔 또 너무 모양이 비슷비슷한데요.
Right. So you have a certain patterns of a tachycardia comes in group, it's changing, right? So what do we call this? Maybe more appropriate if this is a VT, described as a polymorphic VT. Okay, salvageable similar VT with repeatedly coming back. Because if you look at the lead 2, first 2, 3, 4 bit, and then subsequent 8, 9, 10 is pretty close to each other. And there's notching is also similar. But other than that, between 2, keep changing around. So
언더라인 atrial fibrillation에 원더 브랜치 블럭이 같이 있었을 가능성도 배제를 못할 것 같습니다.
if it's a fibrillation, probably wouldn't be this regular. Maybe some sort of a flutter that can explain, that P wave that's slightly dissociated with that earlier someone pointed that there could be a P wave. So atrial fibrillation, unless you have some sort of axillary pathway or something like that, you can do this. But I don't see a specific pattern of pathway here, unless patient has a multiple pathway, which can which explain QRS changes, right? So that's the differential diagnosis we are talking. One is the polymorphic VT. Second is that whether patient has a atrial fibrillation flutter with a multiple axillary pathway is manifesting, and the ERP of one pathway to another. That is also possible. But then the question is, this precordial lead pattern, is it consistent with the WPW? Any pathway does this? I don't believe so. Do you see any pathway pattern? B1 to B6 looks like this. If this is a ventricular arrhythmia, it has become closer to the apex, not the base. WPW pattern is a VT pattern consistent of the base, not the apex, right? Because the pathway inserted in the base of the mitral valve annulus or tricuspid annulus. Because there's no precordial concordance here. As you go toward the V6, become negative rather than positive. So it made the transition probably right. And then I think this is so differential diagnosis is all we discussed so far. Any other differential diagnosis we need to add on here? So
수화상 없답니다.
okay.
그러면 다음 심전도로 넘어가겠습니다. 다음 심전도는
Okay, let's take a look.
환자분이 이제 입원해서 저희 텔레메트리를 달아놨는데 텔레메트리를 봤을 때 새벽 5시 10분에 갑자기 이런
Spontaneous onset VT. Wow.
VF인데요.
Huh?
VF인데요.
Yeah, I think this is if you look at the first 3 bit, I mean, one PVC trigger, okay, is R on T, right? QT is prolonged, looks like here. Am I correct?
네.
And then the TBC occur right at the T wave and then trigger this relatively monomorphic 3-4 beta VT. Then you axis change, then you have another 3-4 beta similar, and then you get that change become more frequent successively. So this do you call this as VF? Can this be VF? Probably not, because if you look at the ventricular fibrillation, we talk about Wigger stage 1, 2, 3, 4. Wigger stage 1 only lasts what? 5-6 seconds at the most? Not longer than that. After that, Wigger stage 2 is a complete chaos. This is not a complete chaos. There's a pattern here. So I think we need to look at whether this is a polymorphic VT or pleomorphic VT. And I would just argue that this could be pleomorphic VT.
네,
But-
플랫폼픽 BT 정의를 좀 정리하고 갔으면 좋겠는데요.
Okay.
그 톨사드하고 폴리모픽 BT는 어느 정도 감별이 되는데 보통
Right.
제가 알기로는 플레오모픽 BT면 그러면 모노모픽 BT로 가다가 갑자기 엑시스가 바뀌어서 다른 형태의 모노모픽 가다가 이렇게 바뀌는 걸로 이렇게 알고
Right.
있었는데 이런
Correct.
오버런스 패턴의 폴리모픽 BT도 플레오모픽 BT라고 부르나요?
Well, you can have a non-sustained consecutive pleomorphic VT because they short-lasting VT. And that can be happen in the presence of severe prolongation acute interval or also in a combined underlying structural heart disease. Now, if you look at the lead V5, you would argue that's a VF, right? Look at the V5, bottom lead, yeah? That's a VF, right? It's keep changing around. But last to 4 beat though, yes, pretty stable. That does not happen in VF. So some people used to call V flutter VF or something like that. So I think there's no clear-cut definition is how many bit of what would be a pleomorphic VT or V flutter. But this is at least much more organized than ventricular fibrillation pattern. Okay. So I would favor for pleomorphic VT, but some people might argue otherwise. Okay, so what did you do with the patient?
그래서 이 다음 텔레메트리가
Uh-huh.
이렇게
Shock했어.
네,
The
그래서
VF went to VF. Okay.
환자분
Shock.
ICD가 있는 분이셔가지고
Ah, okay. So then you still have a clinical PBC coming back again, that PBC short QT. Now, after shock, you can look at the S segment elevation in this patient. First beat after shock. She's the S segment of huge, well elevated, right? That complex. Go to the PRS. Your lead 2, S segment is elevated. Lead 3, S segments are also very elevated. Yeah, right there. Yes. And then you got AVF is also elevated. The rest is all negative. And which is a similar you see in the after the PVC, the narrow looking QRS complex. Last bit on the screen. Yes. Keep going. Lead 3, lead 2, right? So question is this patient is the inferior wall is not ischemic? In posterior wall also looks like involved, but I wonder whether this patient has acute ischemic event. You see the V1s, you have a segment elevation as well.
샥 때문에 트랜지언트하게 올라갈 가능성도 있지 않습니까?
Is it possible? 하지만은 PVC, after PVC, you have this significant change, but why the only inferior leads? We didn't answer that question. Unless this patient has previously aneurysmatic ischemic heart disease involving aneurysm and inferior wall. Otherwise, we can explain this. Okay. So What happened with the patient? Why the patient had ICD? You can tell us now.
그럼 이제 정답을 하도록 하겠습니다. 일단 환자는 55세 여자분이시고 팔피테이션
I see.
뇌를 내원하셨고요. 테트라울러저 팔로스로
Mhm.
1985년에 리페어 수술을 받고 이제 타 병원에서 2007년도에 PBR, TAP, VSD 클로저, RVOT 머슬 익시전을 받던 도중에 환자가 수술방에서 VF 어레스트가 있어서 그때부터
I
ICD를
see.
가지고 계셨던 분이십니다. 그리고 APIP과 AT가 있어서 이미 다른 병원에서 트리드 RF까지 받으셨는데도 계속 파셜리 석세스였고 계속 AT가 있었던 분이고 APIP으로 아미오다론 복용하던 중에 QTC가 길어지면 샥이 여러 번 들어갔었던 과거력이 있고
I see.
에서도 모데레이트 시비어 TR이 있던 분입니다. 그래서
Right,
약제로는 아스피린, 릭시아나, 아토바스타틴의 라식스 알닥톤 먹고 계셨고 레이트 컨트롤을 베라파밀 40ml BID와 그리고 플래커나이드 75ml BID로 복용하시던 중에 이제 나왔던 심전도고요.
So hold on a second now. Let's slow down there. If you have a flecainide on board, if you develop atrial flutter, okay, does not suppress completely, what would happen? In other words, patient has a good AV nodal conduction. If you give a flecainide or any other antiarrhythmic drug, you convert the atrial fibrillation, any of those nature to the flutter, what happened? Your ventricular response rate happened what? Go to 1 to 1, right? Because the flecainide has a anti-dialytic effect. The question, the verapamil 40 milligram twice a day was enough to completely block the ventricular response rate in this patient? Do we know that or no? Because you just described to us that the atrial flutter of fibrillation, whichever patient developed tachycardia, patient has multiple ICD shock, right? That means ventricular response rate is still pretty fast. Otherwise, we would not get a shock. So I'm just questioning whether flecainide is the appropriate drug in this patient. What would you do in the next if this continue to happen? Any other drug that we should consider? Can you guys hear me or no?
예.
Okay.
이 환자가 다른
So,
병원에서 atrial fibrillation 때문에 리퍼가 되어 왔는데요. 아미오다론 스트럭처럴 분리가 있으니까 아미오다론 썼는데 뭐 스톰이 왔었어요. 그래갖고 QTC를 그나마 제일 늘리지 않는 약으로 쓰려고 플래티나이드 50mg BID로 시작을 했는데 베라파밀 40mg 하고요. 근데
right.
atrial tachycardia 그 후에도 자꾸 나타나서 75mg으로 늘리고 나서 지금 이 사단이 난 거고요.
Okay. So second question I have is patient has a very complex congenital disease who had a prior multiple surgical intervention and also ICD VF arrest. So mechanism of VF arrest, we are blaming that to the long QT, but I am not sure that's all the answer here. So obviously concern would be, using sotalol, any of those kind of drugs, right? So one potential drug, I don't know whether you guys have in Korea, would be a dofetilide. This patient.
dofetilide 없습니다.
없어? Okay.
그래서
So
시켜가지고 소탈로를 썼는데 소탈로를 쓰고 나서
right.
두 번 들어갔죠. 80mg 들어가서 이게
Right.
텔레메트리 이게 또 잡혀가지고요.
Okay. Right.
전형적인 로우 QT의 PVC 싱글 PVC.
Right. So I would not use a sotalol anyway because of bradycardia torsa dependency. That's very high, obviously clear. And so I think dofetilide would be, if there's a possibility, would be good. Now, you guys have a dronedarone, right?
있습니다.
Yeah, dronedarone tended to, I think, less prolongation of QT in my knowledge. Anyone has experience on drone-head-on QT interval prolongation? Anybody seen it?
뭐 이론적으로는 클래스 3니까는 큐티가 길어지는 거는 돼 있는데 소팔런만큼 길어지는 것 같지는 않던데.
No, I think drone-head-on may be the one of the drug trial with the beta blockade, and then you have to adjust the ICD for the pacing. That may be an option for this patient. So you're planning to ultimately do what? Ablate or what you want to do?
네, 11월 달에 오퍼레이션 일단 스케줄은 해놨고요.
And how we're going to deal with the TR?
선생님 오실 때 하려고 스케줄을 넣어놨고 TR은 지금 소아심장과하고 상의했는데 지금 당장 손댈 정도는 아니라고 컨설테이션.
Okay. So basically, patient need to be stabilized first, huh? Okay.
현재는
So
저기 메라파밀만 도즈를 올리고
Okay.
엔젤스트런 끊고서 집에 보내서.
okay. So we probably needed to deal with the atrial tachycardia flutter, no matter what, this patient, right? Then I think we can deal with the other issues of a proarrhythmia, whatever we need to do with this. What kind of defibrillator the patient has?
본 거죠?
되게
It's just
오래된
dual chamber?
싱글 챔버인 것 같아요. 다른 병원에서 하는 것 같아요.
예.
Single
이하탈-
chamber.
이하탈이 되었.
I see. So
그 스트럭처 할때 있는 환자에서 소팔롤이나 아미오다를 로우 도즈만 넣고도 아미오다론도 100mg 넣다가 멀티플 샷이 들어갔었거든요. 그런
right,
게 자주 있으신가요?
right. Because of
필요한 스트럭처 할때 때문에 그런 건지 아니면 또
no. That's
있는 건지.
That's not it. If you go back to history, take a look at the history. What did this say? Patient is a tetralogy follow, right?
네.
So they did the surgery. How do we do TFO surgery, guys? This patient had also ventricular septal defect, right? So what did they do? They opened the right ventricle, right? But tetralogy follow also involve what? Left ventricular flow tract. What they do with the conduction system when that happen. So when you have a tetralogy follow, especially with the multiple previous surgery, your proximal conduction system plus Purkinje network is completely abnormal. They're not normal because of scar. So when you add any antiarrhythmic drug, this type of patient that you cannot start any antiarrhythmic drug in outpatient. You gotta admit these people because these things happen quite often. And second thing I'm concerned is this TR. Usually when you see such a drastic proarrhythmic effect, that per se sometimes an indication that you need to just more than surgical repair. Maybe you have to consider even transplant or something like that. So that's sort of one of the second reason we discussed during the multidisciplinary meeting with congenital heart failure and those arrhythmia people together. And this issue comes to arise quite frequently. And you have to remember that this patient outflow muscle excised, but I don't know how big the area excision was and how much tracheal valve reconstruction they had to do. So you may want to look at the imaging very carefully again, make sure we are not missing anything else. And this patient, anyway, they develop high risk for heart block, progressive. So that's why I ask you what type of ICD patient has. If a patient has single chamber ICD, sometime doing just by VICD, often you can control better those trigger PVCs because of biventricular pacing and both side pacing anyway, these people, and they sometimes you can get away with it. In that case, what you would do, you can just create a complete heart block, this patient, just cut the remaining AV nodal conduction. That way patient will have a synchronization therapy 100% and no more PVC and no atrial fibrillation with the RVR. So you would be less concerned about it. That's another approach you can deal with it.
사이너스 EKG.
네, 그게 이제
이 사람이
사이너스
사이너스
리듬일 때.
EKG고 아까
Right.
이제 입이 오면서 그런 나쁜 이름이 나왔지만 사이너스 EKG.
Sinus PR.
우선 저 TOF에 해당한 EKG에 대한 건 좀 설명 좀 부탁드립니다. 저희가 컨제니탈 하트는 자주 보지 않기 때문에.
Right. So your PR is basically upper normal, this patient, or slightly prolonged looking at the eye. But then you have this significant bizarre looking ribond branch block morphology pattern, which extend all the way to the B5. You see that? Notching, sluggish, yes. That means your right ventricle is extremely scarred, this patient, already. And the QRS axis is almost indeterminate in the limb lead because biphasic all three are, right? But if you look at the precordial, the rotation-wise, patient rotating inverse. So if patient has a clearly right ventricle overload already severe, T-wave inversion and lateral lead as well. So that's why I'm just worried about the TR issue that, ultimately you may have to deal with that, okay? Now, an alternative option would be if patient going to have a second or third, whatever surgery, another intervention, that point you can also consider doing, limited maze or some sort of a complex maze, whatever, depending patient tolerance. That way you can take care of the arrhythmia as well as the tricuspid valve regurgitation. That's, often we recommend it to the patients. But many surgeons reluctant to do that because the OR time is very long, pump time is long, and so forth. Because this redo is going to bleed a lot, unfortunately. Patient had already complex surgery multiple times. But that's a lot better than maybe try first transplant and then, if not, transplant the heart. And what's the PA pressure this patient? Do we have any clinical data? An echo?
에코로 매전 했어.
근데 가져오질 않아가지고.
Okay.
네.
So is it just pay attention carefully whether you had a previous echocardiogram, some other hospital, any other institution they did, and you can compare with what you get, this hospitalization. So whether pulmonary hypertension, any dynamics is changing, that would be also another indication that you want to give a head up. And this patient has a normal liver size when you examine patient? Do you know? The patient didn't have any hepatic congestion, anything like that?
리버 펑션은 괜찮아.
예, 리버 펑션.
Okay, yeah. So that's another thing that, we need to pay attention when we do congenital cases very, very carefully. Okay?
네.
저는 질문 하나만 드리겠습니다. 그런
Yes.
하트 서저리하고 뭐 TOF 리페어하고 나서 루틴리 아스피린 쓰는 경우는 대부분인데 이 환자처럼 이제 엔티코아귤레이션 풀도즈를 쓸 때 같이 써야 될 필요가 있을까요?
Right. I think because a patient has least I would do anticoagulation until 100% sure that the patient atrial fibrillations, all those event is completely gone. Second reason is that patient had multiple previous surgery and a TFO repair, all that. You really don't want to have any pulmonary embolism in this patient because they can be fatal for these people. So we tended to be a little bit more generous for the anticoagulation until you follow up with the device, make sure that patient has a free from the atrial fibrillation, arrhythmic event, and all that, then taper down gradually. And, your judgment that if this patient has no renal dysfunction, then you can maybe, gradually use a NOAC rather than anything else. But the patient had the tricuspid valve repair already, PBR, remember? So that would be another indication. Anticoagulation may be better. I don't know what kind of mechanical valve would they put it on PBR? What valve would they put it on?
TBR은 티슈 밸브.
Tissue valve, okay. But if you do tricuspid valve, then I think I would anticoagulate patient. I would not stop because thrombogenic issue.
그러니까 늘 쓰던데 제가 적극적으로 얘기해서 끊으라고 해야 될지 좀 고민돼 같이 보는 환자들은
No. I would not rush to stop the anticoagulation because you got two tissue valve, tricuspid valve, and obviously surgeon may not put a tricuspid valve in the tricuspid. He may put a more long-lasting mechanical valve, but then most now currently surgeons prefer tissue valve, human homogenic tissue valve. But even then, I am not certain their RV function is going to be completely recovered normal. There's already so much scar right ventricle. So they high risk for pulmonary embolism. Then I would not just stop right away. Okay, it's a judgment call, but surgeons may recommend to stop, but usually we don't because any elevation of pulmonary artery pressure in these people would be a devastating result long term. So
먼저 다음에 선생님 오셨을 때 인터벤션 하게 되면은
okay, I'll be there.
다 해야
I'll be,
되는데 선생님.
yeah, I'll be there. Just I think the week before Mongo, Friday, I'll be coming to your lab,
아니,
visit your lab. Okay,
그때는
just
안
let you
되고
know.
있습니다. 11월 15일로 잡았는데요.
Okay, 11월 며칠?
15일인데 그때 선생님께
Okay, you let me know when. Yeah, then I'll.
선생님 언제 오실지
아.
알려주시면 조정하겠습니다.
Okay, I'll be happy to learn with you guys. Not a problem.
감사합니다.
Okay, very interesting case.
아 이것도 있구나. Heart beat is bad.
Okay,
자, 누가 먼저 하겠습니까? 이상준 선생님 한번 할까요? 83세 여자.
QR에서 앞에 선행하는 PAV의 모양이 다른 하나는 사이언스, 하나는 ABC 어딘가
에이트럴 바이저민이. 네.
이게 TV에는 관계 없어져 있지 않아요. 일단 뭐 ABC가 어떤 특성인지 보이진 않을 것 같고 어느 것이 이게 지금 사이너스라고 일본에서 바이페직하게 보이는데
so you ask a very important question. How do we know when the bigeminy, which one is a sinus, which one is not, right? How about you measure PP interval? What happened? You measure same P wave morphology interval. Have you done that? So if you look at the first bit as a lead to is a P waves are upright, right? Consistently. Yeah, that bit, next bit, next bit, next bit. Okay. And then you have a second morphology PVC or whatever you call PAC, whatever it might be. Measure that. Is it the same? No, you skip the one PAC there, my friend. That guy next, there's another P right after the QRS complex. Yeah, isn't that the P wave? Why the T wave is deformed? So you need to start suspecting that what might be the sinus, which one may not be, right? Second is that, what is that? P wave morphology, axis. First, the P wave is taller, and then 2, 3. And negative in V1. Lead 2 is positive. Therefore, which one is you likely more appropriate to be a sinus? Most likely the sinus. The question though, how come? Yeah, first bit looks like a sinus, but then that bit itself, EKG change it quite a bit, a little bit around. So looks like a sinus bit, sinus morphology. That's a different PAC there, so sinus there. Okay. What is interesting about this?
선생님 뭐가 인터레스팅이에요?
Your second bit morphology keep changing, right? They're not saying, yeah, that guy. You go to next bit. Yeah. And you go to next bit. Yeah, P wave doesn't appear to be the same, right? Especially the following one, next one. Go to the next one. Yeah, that's P wave all not inverted almost. Now, how about whatever the sinus beat to the next P interval? They're consistent or they're changing also? Whatever first normal looking P wave to the PAC intervals.
계속 바뀌고 있습니다.
바뀌지, right? So we have basically looks like a bigeminal pattern rhythm with the interaction of PP interval and P dash, that is extra bit interval interaction going on. Depending on coupling interval, what do you have? QRS is the same whenever that happens, or they're also different?
맞습니다.
Same?
다르다고요.
Clear, right? So what does that mean? If it is a supraventricular rhythm, all of them, there's no reason to change the QRS width or axis, right? QRS axis of that second beat, PVC, PAC, whatever you call it, also changing a little bit. So when you look at the bigeminal rhythm, it appears very simple ECG, but it's not a very simple ECG. It's very complex EKG actually, when you look at it. So is there any influence of that second, first and second beat interaction? Do each other? There should be, otherwise we would not see this pattern of PV changes, okay? So, okay, so you showed us the Tom Peters tracing there, and you're showing this interaction. Okay, what do you know here? So first is a sinus, right? Agree?
파란색이 사이너스 리듬.
Right, right. So PP interval, pretty stable, right? Where do we measure? You measure that, right? And then PAC intervals, they're same? They're not same,
네.
right?
달라집니다.
Yeah, right. And then that does what?
점점 인터벌이 감소합니다.
Yeah, right. So what is that doing? Mechanism of what? Why the interval getting shorter? So that's what he's asking his question. When we were his student, he asked this, what's the mechanism of this thing? What are the potential mechanism? Any differential diagnosis we can make it? Is there a certain pattern about this P wave we see? No, there's not. There's a multiple different P wave morphology, PAC, right? And the last 2 bit of a PAC, particularly, come much shorter, right? Than anticipate. So that's QRS morphology change is what? Would you argue for aberrancy or some bit that even did not even conduct, maybe? So that's a differential possibility you have to think about it. Because the PR is much longer, last 2 bit. Do you see it? Back to next one, yes.
왜 커플 인터벌이 짧아지죠? 근데
Right, 짧아져.
왜 그런 거죠?
Yes. 왜 그러냐고?
P-웨이브 몰폴로지는 비슷해 보이지 않나요? APC, P-웨이브.
No, PA morphology, they keep changing. They're not same. Nothing to say.
V1을 보면은 거의 똑같아 보이는데.
Right, V1 is appears to be same, but then if you look at the V1 is, remember, is a unipolar amplifies. Lead 2 is probably is a much more bipolar signal, right? We learned that. So then your X is changing, right? But clearly it's not the same PAC, that's sure. Okay, so that much you read, that's pretty good actually. You done more better than me. When I saw this first ECG, I wasn't even having no idea what's going on. Okay. So if you, okay, comment, HR 받으면 okay? What's that?
잘 모른다 그래가지고
Right.
답이 궁금해.
Mildly irregular parasystole. That was an argument we did, and we argued that there is not a one single focus parasystole, but then, you know, this 88-year-old lady had the atrial myopathy, all those different diseases going on. Why I'm saying that? Because your P wave amplitude, first of all, too low, and P wave duration is also kind of a little bit shorter than anticipated. But if you guess that this PAC, okay, look at the PAC, how narrow it is. Where do you think this PAC coming from? It's got to be close to septum, otherwise you can't be that narrow, okay? So when I argued with Tom about this, is that I told him this could be septal PAC with maybe some exit variation. But he did not take that as an answer. He think that still parasystole from ectopic atrial rhythm somewhere posterior. So, but I don't think that's the answer, at least in my mind. Because if you look at the lead 2, some of them, I mean, change almost 180 degrees, that PAC. Look at the PAC. That guy, next guy, take a look at it, it's slightly negative. And then next one become positive, suddenly. Next one, yes. And then look at the next one. It's like negative. And then, you know, this pattern continue repeat. So I think this is some sort of a, for single focus with the exit, you know, mechanism delay happening because of, you know, PP interval getting shorter. That's what I see. But that might be, you know, also potential discussion. That's what we, you know, ended it. But is something that you think about it, okay? So bottom line is that when you guys do bigeminal rhythm, always try to figure out which one is normal first. And then recognize the second bit is abnormal, and then you keep looking. Now, if you go to the previous tracing, I just point out one thing quick. Go to previous tracing. Okay. If you look at the carefully here, look at the number 4 bit. 2 sinus, okay, next step bit. What do you think of that T wave? Do you think there's another P wave here? That's another argument I had with him. I told him, I think there's a P wave, but he said, wasn't sure. But if you look at all the precordial lead 2, 1, and 3, which is the same corresponding EKG.
있는 것 같은데요?
Yeah, I think so. There's a P wave. And I told him that could be echo beat, but he says no. But, you know, it is all debatable. You know, Dr. Peter, once he made his mind, and that's it. You cannot change him. So, but I think there's a P wave, okay? That much I can tell you. So that's how I was pointing earlier.
Okay.
So in the bottom line, all complex arrhythmia, sometimes we can only raise a differential diagnosis. We cannot make a final definitive diagnosis. And a lot of these cases, we end up taking to the lab and then to learn what is actually happening to the patient. But this lady, we never was able to take to the lab because she refused the B study. So, okay. Right. Very interesting. Okay.
잘 들었습니다.